Hello and good evening. Assalamu alaikum. My name is Gerard Moore, and on behalf of ACPN, we'd like to welcome you to the second webinar of the Headaches Patient Series 2021. The date is 17th of March 2021, and the time is 7:30 here in the UAE. Today's webinar will be brought to you by obviously Dr. Mustafa, a very well-known consultant neurologist at SKMC, and Miss Ghena Yaacoub, who's a clinical psychologist at the American Center of Psychiatry and Neurology. They will both be presenting for 20 minutes each, and then the final 20 minutes of the hour will be given over for Q&A. So please write your questions in the question box on your right-hand side. If you have any audio or video connection problems, you can press the red reconnect button located on top of your screen. And if you wish to message me privately, you can press the admin only button and we will receive your private messages and private questions. Without further ado, I'd like to hand you over to our most eminent of speakers, Dr. Mustafa. I'm sure you all know him. He's consultant neurologist at SKMC. Dr. Mustafa will be now sharing his screen. The floor is yours, Dr. Mustafa.
Thank you, Gerard. Thank you, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Mustafa Shakra. I'm a neurologist at Sheikh Khalifa Medical City. My talk today about headache, and I hope this is, I may have tried my best to do it in very easy way and very simple method in order to be understood by majority of you. So usually what we mean by headache, any pain in face or head. Gerard, do you see me? Everything is okay?
Everything is clear, doctor. You can continue.
Okay, thank you very much, Gerard. So again, headache is any symptom of pain in face or head, regardless if it's posterior, partial, full head, every part of the head, any part of the head. If there is pain, this is headache. People comes to us, tell this is not a headache. This is only this part of my head or this part. But again, any pain in face or head is headache. In 99.9%, this is completely is a benign issue. Is not, there is no malignancy usually. So see, the vast majority of complaint of headache is completely benign. So people comes to the clinic because of concern that something wrong in the brain. No, at all. Vast majority of presentation of headache are benign, and there is no any structural damage in the brain. And usually the brain itself doesn't have any receptors for pain. However, what we feel the pain because of the structures or membranes around the brain, which known as meninges, as السحايا in Arabic, and or blood vessels, or even the skull itself. So as you can see, majority of cases here of the headache causes are primary. That means it is from inside the dysfunctional brain function related to transmitters problem, but structural wise there's nothing. So 99.9% it is usually benign. These cases, majority of them are tension headache. Around 16 to 25% are migraine, while there are many other types of headache that are extremely uncommon. Now, the less than 1% cases, this is what patients usually concern, either tremor. As you can see, it is very, with an account, it is 0.1%. It's very rare, extremely rare. There is other issues that can cause headache, vascular issues, malformations, sometimes head injury is very common, and infections, as usually, meningitis or encephalitis are cause of headache. So because of this, majority of cases are benign. We usually don't need any imaging studies. So people asking for MRI or asking for CT, there is no need for such cases. All the diagnosis is made completely based on the story of the patient, on details that patient is giving for characteristic of the headache. This is the main source for us to confirm the diagnosis. So in very rare, very extremely rare cases, we need to go for any imaging study, either CT scan or MRI. What we need to ask, what the story has to tell us, a lot of issues. In fact, we have to dig inside this this information that we are getting from patients, how it starts, is there any causing for any problem, is related to hunger, is related to exposure to sunlight, is related to food, anytime, evening, morning, waking up from sleeping, how it start first time, it was related to any head injury, no head injury, any family history, where is the pain, where is it, right, left, goes all the part of the head, how long it lasts. This is very important. For how long it starts. Some people comes to the clinic because 25 years of headache, and at some point they think that this is something is bad. Then we ask about the severity of headache. How severe is it? Worse? It respond to simple analgesics like acetaminophen, Panadol, or not? Is there any other associated symptoms? Majority of cases of headache, benign headache, are associated with nausea, vomiting, sensitivity to light, sensitivity to noise, a lot of other symptoms. Anything help? Sitting, lying down, sleeping, taking some medication. And again, how long? For how long there is a headache, or for how many years? This is very important. And how long is the attack of headache persist? We said before that the majority of cases of headache are tension type headache. It's almost 70% of type of headache are related to tension, either chronic or daily headaches, sometimes episodic. Pain usually is not affecting the daily activities of the living. Patients are suffering from pain, but it is moderate, it is mild, it doesn't affect the daily activities. Patients go to their duties, to their work, to their school, they're no effect. Usually it variable in time, in how long it lasts. Sometimes very minimal, like 30 minutes. Sometimes it takes 7 days or more. Again, it include all the parts of the head. Sometimes also radiate to the neck. The most important thing that this is only headache. There is no associated symptoms. Patient doesn't have any sensitivity to light, sound, any visual symptoms, any nausea, any vomiting at all. And usually it affects any person. It's not any even gender, male and female, any age can be affected. This is usually it is bilateral, as this sometimes it goes to the neck even. It takes either here banding, heart band like this, sometimes characteristic, pressure like, sometimes only aching. So patients telling different characteristics of the patient of the pain. It's usually pressure like. It's usually even in this area here of the posterior part around the neck and the posterior part of the head. And we thought that this is probably related to stresses, and stresses induce some transmitter abnormalities inside between the communication of cells inside the brain. We have a few effective treatments. However, there is sometimes many even non-drug treatments, as we'll see later on in the presentation of Dr. Ghena. Now, the most important probably type of headache is migraine, and migraine in عربي الشقيقة، ولا يعني الشقيقة شق واحد من الدماغ يصاب، أو شق واحد من الرأس يصاب بالألم. So this is the frequency of migraine is variable. Some people suffering from one attack of migraine every year or two. Some people are getting 2 to 3 attacks. Attacks usually may persist for up to 3 days. The headache is usually pulse-like or throbbing-like, and usually there is a lot of associated symptoms. So migraine is not only headache. There is a cocktail of symptoms, including nausea, vomiting, sensitivity to light, symptoms, irritability. And usually it is even affecting or impacting the performance of the patient. Patients who are having migraine avoid to run any duties, either household duty or their job duties. Usually it is on one side of the head. However, in even 40 to 50% of cases, it includes 2 sides of the head. So you at any time can, even in with children, we see also migraine, teenagers, also young adults, and so it can start at any age. It's usually affect women more than men. It is probably threefold among women than men, and usually in their productive age, very young, in their 20s or 30s, they are affected by this type of headache. And as we said, it is not only headache. So prior to headache, few days patients start getting some symptoms like craving to food, yelling, the disturbances in mood, disturbances in appetite. Then there's just 1 hour or two before the headache start getting the visual aura, which is disturbances of vision for little time. Then include the headache attack, which is usually not only pain, as we say, there are vomiting for sensitivity to light, sensitivity to sound, or even smelling abnormalities. So persist up to 3 days, then followed again by same symptoms like prodrome symptoms. Again, there is mood depression, there is food again, intolerance, there is feeling of high or low, sometimes more than diuresis, then to return to normal. So attack itself probably 2 to 3 days. However, because of this pre-prodrome and postdrome, sometimes one attack take 1 week. So migraine is usually, there is strong family history. So in 50 to 60% there is family history, although some patients says, okay, no, nobody. But if they dig more and more in the family, they found somebody suffering from headache. But they said this is probably related to sinusitis, related to hypertension. It's usually migraine, but undiagnosed. And the mechanism behind the migraine headache is related to neurotransmitters inside the brain disturbances. This is require some more science, and this is beyond the scope of this lecture. So what the triggers usually is related to foods, some food spices, wine, chocolate, citrus, some food additives, some sleep disturbances, the emotional stresses, even hormonal changes among women. This is very important, and usually a majority of ladies are suffering more from migraine during their menses or menstrual period. A lot of other also triggers, including exposure to computer lights, exposure to sunlight, sometimes hunger, during especially Ramadan, smoking or exposure to smoke, a lot of triggering factors. When we ask patients about triggering factors, they are suffering from 20 years. When they come us, oh, I did not notice any triggering factor. Then the next visit, when they look probably more carefully about trigger, they find some triggers that induce the headache attack or migraine attack. This is what they usually see in the visual area. This is the visual field. As you can see, blackish area around the areas of vision, sometimes something like star or flushing. Some areas, like again here, they don't see carefully, they see part of the objects are either flashing or not clear, as here again. This is what we mean usually by visual aura. So just one note, only brief note about what we are usually, in fact, teaching our patients to avoid taking over-the-counter medication. What they consider that this is benign, like acetaminophen, Panadol, or Buffet is not benign, because at some point they will get headache that is worse by taking this type of medications. So usually we educate patients to avoid this type of therapies, avoid taking them frequently, because after 2 or 3 months they will be dependent on this medication, and this medication itself will induce headache. And on the top of them, the medication that include codeine, like Codamol or Tylenol 3, all this medication can cause and induce and make medication overuse headache. And patient, in addition to suffering from migraine, they will again suffer from this type of headache, which is difficult, in fact, to manage. And in many occasions, we have to admit to the hospital in order to manage this type of headache. This is brief about cluster headache, which is again very infrequent type of headache. It's severe pain, especially around the eye. It persists from a few minutes till 3 hours. Again, it's affecting male. Usually it's around the eye, and it's associated with severe pain, and male usually male and smokers are affected more than women. This is what patient feels, as if something is stabbing in their eyes. It's very difficult, and some patients, because of severity of pain, push themselves to even suicidal attempts. And patients can hit their heads. It's difficult. It's extremely painful. Fortunately, it is also extremely rare. So again, type of trigeminal pain, which again rare pain, which is facial pain. It's affecting the area either around the eye, above the eye, or above the oral areas. And again, attacks like knife. It's usually induced by speech, talking, or brushing teeth. It is very, very brief. It's around 1 second. It is sometimes very frequent. and again is affecting women, elderly women more than men, sometimes affecting men with other diseases like multiple sclerosis. Other types of headache are extremely rare. They are beyond the scope of this presentation. Treatment, initially, when we sit with the patient for the first time, we have to explain the situation for the patient. We have to advise for lifestyle changes, remarkable. Again, we have to set realistic objects, because people comes to the clinic asking for a cure. There is no cure for majority of these type of headache, that it is resolving, it is persisting, but fortunately, we have a lot of treatment that are very effective in controlling pain and preventing the frequent attacks of the migraine or even tension type headache. So usually when we treat pain by pain reliever, and we have for specific treatments for migraine, especially triptans. Now we can use sometimes Advil or ibuprofen for treating of tension type headache. For cluster headache, that is a severe type of headache, the most important treatment is high pressure oxygen, and sometimes we can use a triptan like Imigran or Zomig. So when it comes to this type of medication, as you can see, all of these medication are effective. Aspirin is effective and probably fastly effective. Tramadol is effective also. Ibuprofen effective. However, for the long term, we have, again, like in codeine, we have to avoid due to complications, either adverse event or of constipation or dependence, or even medication overuse headache. Sometimes we use some medication that are used in vomiting. Sometimes caffeine is good to control the pain of migraine. We have all the time to avoid the morphine and its derivatives. This is not effective, and again, it will induce dependence on even short term, not even for long term. So we have to look for the fast, effective treatment and safe treatment to control the acute attacks of pain. Now, when it comes to Imigran, Zomig, majority of you know about this medication. This is very much effective. It is effective against migraine. It is effective against the cluster headache. It has to be taken as early as possible, and it has a lot of formulas. If oral medication cannot be taken, especially if there is vomiting, there is a nasal spray and there is injections. However, for patients who are having high blood pressure, chest pain, we have to avoid them. They are expensive, of course, and majority of you know about them. Occasionally, frequent taking of this type of medication can use, again, medication overuse headaches. When it comes to preventive therapy that we are using to prevent migraine or prevent tension type headache, we have many medication available. We borrowed this medication from other diseases, so this medication were not purposed initially to treat migraine. So some of them for treating blood pressure like propranolol, for depression like amitriptyline, for epilepsy like topiramate, and they are working, but not in everybody. And of course, some of people are responding to them, and many of them are not responding. However, usually we can say that they are responding, they are inducing or reducing the frequency of attacks. And we have, in fact, there is nothing, no specific guidelines. We have to go for trial and error. Okay, usually we start low dose and go slow, and by the end, around 50% of patients will get 50% reduction in the attacks of headache. See, if you can see here, propranolol is fairly effective. It's good tolerability and safety. Amitriptyline, again, and topiramate are also have a good effect with very fair safety profile. We have to avoid this medication, especially in migraine, when it comes to preventions, because of either adverse event or no effectiveness. Botox also have a role in chronic migraine only. Chronic migraine, when patient is suffering from more than 15 attacks per month, as you can see, this is multiple injections, either here in forehead, here around the ear, in the back of the neck, and in the shoulder. This is supposed to be taken every 3 months. It has to be tried at least 3 times to be sure about effectiveness. Now, the new modality of a treatment that is made and purpose to treat migraine is injections, monthly injections of CGRP. We have currently in the market 3 of them available in United Arab Emirates. They are very effective, and hardly they are having any adverse events. and they are very tolerated from the very much tolerated from the patient. There are some oral not available yet. It will be available very soon in the market. When it comes to tension type headache, we have amitriptyline, in fact, is fairly effective and with very much tolerated adverse event profile. Non-medication treatment, in fact, we have some herbal medication, we have some manual physiotherapy. Please be sure that physiotherapy itself, like go and do massages or something, is not, we have to be cautious when you taking patients coming to ask about referral to physiotherapy. It's unlikely to get any benefit. Acupuncture, laparoscopy, again, is not effective according to what we have available in science. We have some electrical devices newly available in United Arab Emirates. We will go through some of them now. Again, which is most important, probably referral to psychology, as Dr. Ghena is going to explain after a little time about biofeedback and other psychological approach for to treat chronic headache and headache, generally speaking. Now, this is some machine Cephaly, which is in fact electrical stimulation for some nerves in the face. It is available now in United Arab Emirates. Unfortunately, it's not available yet in our Sheikh Khalifa Medical City, but I think it's available probably in Cleveland or some pharmacies in United Arab Emirates. Again, there is another type, which is vagal nerve stimulation. Again, during headache, both of them are effective in 30 to 40% of cases to control the acute attacks. Application supposed to be for some limited time, and it's good effect in terminating the pain. This is another type of stimulation also. I'm not sure if this is available in the country or not. I'm sure only Cephaly is available. The other machines, I'm not sure about availability here in United Arab Emirates. By this, I would like to thank your attention. I'm waiting for a question. Thank you very much.
Thank you, Dr. Shara. We will have the questions after our second speaker, Ms. Ghena Yaacoub, a clinical psychologist from ACPN. I will just bring up her slides now, and I will leave the floor to Ms. Yaacoub. Okay.
Thank you, Ed. Good evening, everyone. Thank you for attending our session today. And I'll be covering the psychological approach. But before I start, I just want to share with you a picture of how headache used to be treated in 1895. As you can see, this involved blasting the head with a large hammer to alleviate the pressure. Luckily, we don't use this technique anymore, and modern psychology has developed more effective, non-invasive approaches to treat headaches. First, it's important to highlight that headache treatment consists of a combination of both pharmacological and non-pharmacological behavioral treatment. And this combination has a better outcome and a significant effect on reduction of headache frequency. When it comes to psychological approaches, we implement behavioral therapy that comprises three main techniques that should be administered in conjunction for headache treatment. The first one is the cognitive behavioral therapy, second, biofeedback, and the last one is relaxation techniques. The goals of the behavioral therapy are many. Training in the use of behavioral techniques were designed to modify the sensations, thoughts, and feelings identified by the patients as forming part of their headache syndrome. Cognitive and behavioral interventions may improve the quality of life of patients by enhancing their coping strategies for psychosocial stressors and encouraging treatment adherence. It helps also in preventing or at least reducing the number of headache episodes. The second technique is the cognitive behavioral therapy, which is based on the cognitive model that shows how thoughts about situations influence our emotional and behavioral reaction. So how we think, how we feel, and how we act all interact together. Cognitive behavioral therapy is a short-term therapy structure that show the connection between thoughts, emotions, and behaviors and how they can influence each other. It is also a solution-focused approach to treatment oriented towards solving problems and learning skills. In cognitive behavioral therapy for headaches, therapists help you change thought patterns that are maladaptive, and changing behaviors that may be increasing the likelihood of having headaches. Cognitive behavioral therapy also focuses on identifying and modifying thoughts associated with anticipation of a headache, which can cause anxiety between episodes. CBT interventions alert you to the role of cognitions in stress responses and the relationship between stress, coping, and headache. It can also help limit the anxiety and depression that often afflict the person with more frequent and severe headaches. As we all know, psychiatric comorbidities such as anxiety and depression can have an impact on the frequency of headaches, the intensity, and the adherence to treatment. And this should be managed with the CBT therapy, cognitive behavioral therapy. The second technique is the biofeedback. Biofeedback is a technique used to learn how to control some of your involuntary body functions. This happens by attaching electrical sensors to different parts of your body, such as your neck, fingers, scalp. And these electrical sensors are used to monitor brain waves, breathing patterns and respiration rate, heart rate, muscle contraction, sweaty gland activity, and blood flow and temperature. For example, during the biofeedback session, we can pinpoint tense muscles that are causing headaches. You then learn how to make conscious physical changes in your body, such as relaxing specific muscles to reduce your pain. Also, when your temperature drops, this means you're under stress, and this can prompt you to begin relaxation techniques. And all this can be shown on a monitor, so we can tell what is changing in our body. Why we use biofeedback? We use biofeedback because it's non-invasive. It can help you control symptoms of your condition. It helps to reduce or eliminate the need of medication. It enhances the benefits of medication. It is safe for pregnant women. It helps people feel more in control of their health. We have, Jared, we have a slide missing, sorry. Okay, it's okay. So we have different types of biofeedback, and it depends on what we want to test, temperature or muscle contraction. And the next one is the relaxation techniques.
So, sorry, Ghena, let me just bring up, I think I believe the old slides. Bear with me.
Yeah, better.
Yeah, here we go. I think these are new slides.
Sorry about that.
My apologies. Okay, here we go. So we have, as I mentioned, different types of biofeedback. The thermal biofeedback that measures the skin temperature. The electromyography EMG measures muscle tension. Neurofeedback or EEG. Biofeedback focuses on electrical brain activity. Biofeedback can also be employed in the treatment of different disorders such as anxiety or stress, asthma, attention deficit or hyperactivity disorder, ADHD, chemotherapy side effects, chronic pain, constipation, high blood pressure, irritable bowel syndrome, ringing in the ears, stroke, urinary incontinence, and many others, definitely. Okay, this is we went through it. Okay, so the last technique or the last thing to do with the headache is the relaxation techniques. We have so many relaxation techniques, but here I mentioned the progressive muscle relaxation, diaphragmatic breathing, autogenic training, guided imagery, and mindfulness meditation. And usually biofeedback is used in combination with these relaxation techniques, so we cannot do only biofeedback alone. Okay, so we have a variety of relaxation techniques that can be used to calm the body physiological response to stressors by gaining a sense of self-control over our symptoms. I will start with the progressive muscle relaxation, which is a method that helps relieve the tension where you have to tense a group of muscles as you breathe in and you relax them as you breathe out. Eyes are closed and we proceed from forehead to toes and then in reverse order. It can take 10 to 20 seconds, and you can use videos or audio as relaxation facilitator.
The second technique is the diaphragmatic breathing or deep breathing. During diaphragmatic breathing, you should lay down in a flat position with the hands along the sides of the body and palms upward. You start taking deep breath through the diaphragm. When taking deep breath, our body is able to exchange carbon dioxide for oxygen, which results in a slower heart rate and lower blood pressure, which gives us a feeling of relaxation. In addition to this, deep breathing acts as a form of distraction from the source of negative emotions. The last technique is the mindfulness meditation. It's a combination of both mindfulness and meditation. As we all know, mindfulness is the practice of being present in the moment. And the mindfulness meditation is a mental training practice that teaches you to slow down racing thoughts and let go of negativity and calm both your mind and body. And of course, this takes a lot of practice to nail it. Before I end my presentation, I just want to give you some practical steps that are really helpful in managing our headache. Incorporate more breaks in daily life and avoid hecticness. Pay more attention to your own needs. We're talking here about self-care. Establish regular sleep times all nights in the week. Endurance sports such as cycling, jogging, walking, swimming also. And it is important to exercise regularly, at least 3 times per week and for about 30 minutes. Establish regular meal times all days in the week. Try to control potential trigger factors. Thank you, everyone.
Thank you, Ghena. Thank you very much. If I can invite Dr. Mustafa back to the panel. We will begin the panel now. We've had some questions coming in, both in the public and the private for both of you. So I will begin now. Actually, the first one for you, Ghena, is how long did it take to do biofeedback to see results?
It takes from 6 to 8 months to see results. And the session lasts from 30 minutes to 60 minutes.
Okay. And is that every week? Do they have to go?
It's every week, but we have to know that biofeedback alone doesn't give us the best results. It should be combined with cognitive therapy, with behavioral therapy, and with the relaxation techniques also. Very
interesting. Another question regarding to biofeedback, does that help with mental health issues as well?
Well, if we're gaining control over our body and our physiological response, then yes, definitely it will help to control better, for example, our anxiety response and the response of the body to any mental disorder.
Okay, fantastic. Dr. Mustafa, a question here for you. It says, I have pain medications which sometimes bring on attacks. It is hard to balance them. I find it difficult to manage my mental health as well. What do you advise best to manage my migraine attacks in this case? Your microphone is on mute, Dr. Mustafa. It's this, can you activate your mic? Yes. Oh, you can't. We can't hear you still. Sorry, Dr. Mustafa. Can you maybe log out and log back in again, please? I believe the connection is lost. If you can just log out and log in, we'll be able to hear you again, please.
Can I ask, Mariam? This is the question you were trying to answer, Jared, right?
Yes, yes.
Okay, so in that case, you should combine, like, if you're seeing already a psychiatrist or a neurologist, you should also maybe try to see a psychologist, because we can help you to deal better with your mental health issues, and it helps with the adherence for medication also.
Thank you very much. Actually, Dr. Mustafa has joined us again.
Okay now?
Hello, Dr. Mustafa.
Is it okay? Hello?
Yes, we can hear you.
Okay. So what was the question, please?
Dr. Mustafa, can you hear us?
I'm hearing you. Yeah. Would you please just repeat the question? You hear me, Ghena?
Yes, I'm going to repeat it. I have pain medications which sometimes bring on attack. It is hard to balance. What can I do? Also difficult to manage my mental health. I guess that was the question.
Bring attacks?
Bring on attack, yeah.
I think I did not understand well the question. So, where I can find the questions in the chat. Do you hear me, Gerard? Gerard, I think the problem was from your side, not from my side.
We have another question for you, Dr. Mustafa. What about using venlafaxine in migraine prophylaxis?
I think, yeah, we use venlafaxine in a few cases. It is there has been many studies that had shown very good effect on using venlafaxine Effexor in controlling migraine attacks and preventing migraine attacks. We use it, and it is also well studied, and there are a few trials, or many trials in fact, in literature that support is the good impact of venlafaxine in preventing migraine.
Okay, one more question.
Especially when there are also associated depressive symptoms.
Thank you. Gerard, are you back?
Yes, thank you. Sorry about that,
So
Doctor.
the problem from your side, Gerard. From me.
Yeah, always, yes. Thank you, Doctor. I have some private questions that have come in, if I can maybe put them to both of you. One of them is speaking about how many days a month is considered a serious migraine? When should I see a doctor? How many days per month when I'm experiencing migraine attacks?
In fact, it's not only the duration of headache, the severity of attack. Sometimes patients are suffering from 2 attacks per month, but the pain is remarkably severe and not responding even to rescue therapy of triptan or other medications. And patient has every time to go to emergency room in order to get IV or systemic analgesics with hydration. So it's not only related to duration. However, when patient is suffering more than 4 attacks per month, even if there is good control, it's better just to see a neurologist. Probably it's even better to go for some preventive therapy.
Thank you very much. You touched, Ghena, about meditation, and somebody on private forum has asked me about, do you advise, do people meditate every day? What if they don't have time? What can they do? Do you have any apps or anything that they can do very quickly each day to help with meditation techniques?
It doesn't take much time, so they can do it only for 20 minutes a day or even less sometimes. And for application, honestly, we can find it online. We have a lot of application, or just on YouTube, you can have sessions of meditation that they can see. And if they cannot do it every day, it's fine as a beginning. Once they start practicing, they will need it every day. They will see the effect, and they will request it every day.
Exactly. You also mentioned about exercise briefly, and if you could just, this person wants to touch upon what are the certain exercises which work best in preventing or preventing migraines?
Like he means workout?
Types of exercises, yes. Do you have any?
Okay, as I mentioned, endurance sports like jogging, swimming, and walking even, it can help.
Usually we recommend for aerobics, and we advise patients to avoid the pressure or stretching, severe stretching exercises. So, and even exercises that include head injuries like football or cricket or some sport activity that include head injuries.
The follow-up question to that is over-exercising a trigger for headache?
It is, of course, yes. It is. Physical stresses and physical, even long-term physical activity, especially that are associated with some head injuries or some increased pressure inside the chest or abdomen. It is, yes, associated with increased severity or induce even headaches. Okay.
I will leave the private questions for now. If anyone wants to ask any private questions, you can click the admin only button and I will receive them. On the public forum, we have a question with regards to a specific drug, and now we cannot answer that. This is a patient forum. But the premise of the question is, if people are not seeing improvements in certain medications, how long should they leave it before they need to change or should be thinking about changing course of treatment?
For preventive therapy, you mean?
Yes.
Okay, usually we start preventive therapies. It depends. The oral medication, the old type or traditional medication, we start even low and go slow. Then we keep, if patient shows improvement, we keep this patient on this medication for 2 or 3 months. Then we try to withdraw or stop this medication over 6 to 12 months. Now, for new modalities of treatment that are the injectable, the monthly injections, we also show the improvement very early from the first month, sometimes from the first week, and we keep them again for 6 months. With 6 to 12 months, we try to stop this medication after being very much effective or controlling the pain frequency and severity. We try our best not to keep patients more than a year on these medications, any type, old or new.
Thank you very much. Next question that's coming is what is the best thing to do during a severe migraine attack when I cannot take any medications due to nausea and vomiting? What should that person do during an attack?
We usually, for a patient who is presenting with severe attack, with nausea and vomiting, we suggest, in fact, to use either nasal spray or injections if they have injections, subcutaneous injections for triptans. Otherwise, he has to seek medical attention by any emergency room nearby his, probably where is he. Okay, so otherwise it's not good at all to try any oral medication because of gastroparesis. There is something like it will make difficult, even if he gets some oral medication, it will be difficult to be absorbed and be effective. So it's better just to not to waste time and try to get nearby AR or emergency room to get systemic injections, systemic analgesics.
In terms of family planning, are any of the current or recent medications, are they helpful or a hindrance to family planning?
We usually recommend for strong family planning to consider strong contraceptives whenever patients are starting on a preventive therapy. So all the current medication not available, none are not advised to be used during pregnancy, are contraindicated even during pregnancy.
There's a question here about sleeping. It may have been when I had to lost connection for 1 minute. But did you answer that, or should I ask that?
No.
Okay. Okay. My bad sleeping affects headaches. Should I take sleeping medications to help? And will taking magnesium help with it?
For sleeping, we recommend also, we advise for sleep hygiene, good sleep hygiene. We teach patients about sleep hygiene usually. We try to advise, give some advices, try them. Unless, in case there is no response, sometimes we start melatonin. Melatonin has good effect against migraine, even in the prevention of migraine. It's very good medication. It's used widely in some countries as preventive therapy. Otherwise, if there is even no response, we can use either amitriptyline or sometimes we go to some sleep medicine, some medications. Yeah. Especially if there is tight correlation between sleeping disturbances and migraine attacks and severe migraine attacks.
Thank you. This one for Ghena. Where to do muscle relaxation? Is there ACPN or other places in the UAE to do it?
Progressive muscle relaxation is a technique you can do it at home, and you can we'll teach you in clinic how to do it, and you have to practice it at home. So it can be done anywhere.
Thank you. What about stress as a factor in the post-COVID or the current COVID age of high stress? Are you both seeing an increase in headache patients in your practices?
Seeing increase in patients in headache also.
We encountered, yes, some more referrals for headache after the COVID pandemic or during the pandemic. Usually, even acute infection of COVID is associated with headache. And in some patients, there are some even post-viral, there are patients who start suffering from headache or migraine, even tension or migraine headache after being infected by COVID. We encountered few or many even cases from post-COVID migraine. So, but digging more in history, families or personally, they probably has some type of headache that is becoming now more severe and more prominent after getting the infection. Yeah.
I believe you covered this, Dr. Shara, in your presentation, but this person has asked, is migraine related genetically to family history? And what percentage of migraines?
In literature, you find 50 to 60% of migraines are in fact related to genetics or hereditary or familial. The genes here are polygenes. It's not one gene. Again, it is a susceptibility genes. It is not that you are carrying this. They are first polygenes. It's not one gene, and they are susceptibility genes that put you at risk to get migraine, not to be suffering from migraine. So having these genes doesn't mean that you are having migraine. However, probably in some stresses, environmental stresses, this brought you at higher risk to get migraine.
And I have two final questions on the private chat bar, and if anybody else wishes to ask a question in private or public, they can do so now. I will go ahead and ask them. This person's asking about the role of beta blockers, and are they advisable to take, and do they help with migraines?
We have been using beta blockers for probably 50 years or more, even in the prevention of migraine. On top of them, also, of course, propranolol. It is safe and it is effective to some extent. It's almost 50% is effective. It is very well tolerated by majority of patients. Even in sometimes we use it during a pregnancy in ladies who still suffering from migraine during pregnancy. So it is relatively safe even during pregnancy.
And the follow-up question the person has asked is, you mentioned that some OTC drugs are not recommended. Are there any that you do recommend for OTC drugs?
This is for me?
Yes.
Okay, we generally speaking, all over the counter medication, which are short-acting analgesics, are not recommended, recommended to take very frequently during a month. If you are if you are using this medication for 8 days or more during a month, patient is exposing himself or herself to the risk of medication overuse headache after 2 or 3 months of getting this medication. Patient get good relief after getting this medication. They try to get every time. Whenever they start getting headache, they get this medication. It's easy. They are handy medication, so take them easily, and they don't think about this potential very bad adverse event. After 2 or 3 months, patients start getting not even headache, migraine headache, another type of headache, which is it is medication overuse headache. So it is usually all short-acting, over-the-counter medications, including ibuprofen, paracetamol, Voltaren, even triptans, something like Imigran, something like Zomig, Railbacks, all this medication. And on top of them, in fact, codeine. Patient loves codeine. Codeine is very effective with paracetamol. But by days, and they are depending on this type of medication, by 2 or 3 months, start getting a medication overuse headache, which is remarkably difficult to treat, in fact. Many occasions, we have to admit patient to hospital. We have to do what we used to call detoxification therapy, in order to get to let this patient get out of this dependence on this type of medications.
Thank you. Okay, and the final question that we have for today is, my migraines begin to feel worse this time of year or when the weather changes. Is this true of many other people?
Of course, yes. Weather changes, exposure to sunlight, weather changes, cold weather. Sometimes, yeah, there is tight correlation between weather changes and migraine attacks. So migraine frequency and severity increases in some weather. Especially here, people are during the summer are suffering from more frequent attacks of headache. When they go to Europe for like vacation, they enjoy their time. They don't get any headaches even. So it is there is tight correlation between weather changes and migraine, of course.
Okay, thank you. Actually, just one last question on the public chat bar. Is Zomig safe for ladies over 60 years?
Generally speaking, it is safe. We try to avoid this type of medication, not based on the age. It's based on if they have background of vascular diseases, like uncontrolled hypertension or severe coronary disease or history of stroke. In these cases, we try to avoid this type of medication, not only Zomig, Rilbax, Imigran, all this family of medications.
Thank you very much. Thank you, Dr. Mustafa and Ms. Ghena. If I can ask you, where can any of the patients or people, guests here today, where can they find you if they want to book an appointment with you both?
They can find me at American Center for Psychiatry and Neurology.
I'm available at Sheikh Khalifa Medical City in Abu Dhabi, clinic number 5.
Thank you very much.
Abu Dhabi, yeah, definitely.
Thank you very much. Thank you very much. This was webinar number 2 of the ACPN patient headache series. We will have one more before Ramadan. That will be on Wednesday, April the 7th. That will be managing migraines during fasting, a very topical one for that. And that will be with Dr. Tawfiq Al-Sadi. So please save your dates for the 7th of April. And then we will return for 2 more after Ramadan. This brings to end today's webinar. I'd like to thank Dr. Mustafa Shara, Dr. Ms. Ghena Yaacoub, the webinar sponsors Novartis, and of course the American Center for hosting today. I will now end the webinar. You can watch it on replay for the next 7 days with the same link that you had today. Thank you all and good night.
Thank you very much.
Thank
Have
you.
a nice night. Thank you. Bye-bye.